Okay, well, hello everyone, and welcome to our webinar today. Just want to make sure everyone can hear me. Veronica, can you hear me?
Hear you just fine.
Okay, great. So thank you everyone for joining us today. This is Jean Pulvermacher, and I am with the Great Lakes ATTC. We are happy to have Dr. Westergaard here today, who's going to talk to us about what addiction treatment providers need to know about HIV and viral hepatitis. Just a little bit about the Great Lakes ATTC. We're one of 10 US-based regional and 6 international HIV ATTCs across the country and the world. The Great Lakes ATTC serves Health and Human Service Region 5. We cover the states of Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. And we are funded by the Substance Abuse and Mental Health Services Administration. About this webinar series. This is a first webinar in the two-part series, and it's going to focus on HIV and viral hepatitis and how it relates to addiction treatment. So webinar 1 is today, and we're going to talk about Syndemics Part 1, what addiction treatment providers need to know about HIV and viral hepatitis. All the webinars will be recorded and available for viewing along with the PowerPoint slides. And I just want to let everyone know that the next webinar will be July 19th, again at 12 noon Central, and we will have registration up shortly for you to register for that webinar. Just some housekeeping. Today's audio will be broadcast through your computer speakers, so please make sure they are turned up and on. There is no call-in number available. If you have any questions, please use the chat box throughout the webinar to ask or add comments or questions. And then after the presentation, we'll also have a Q&A session using the chat box as well. So without further ado, I want to introduce today's presenter, Dr. Ryan Westergaard. Dr. Westergaard is an assistant professor in the School of Public Medicine and Public Health at the University of Wisconsin-Madison. He attended medical school at Johns Hopkins University and completed a primary care internal medicine residency at the University of Colorado at Denver, where he was also a staff physician at Denver Health Medical Center. He received fellowship training in infectious diseases at Johns Hopkins Hospital and the Johns Hopkins AIDS Service, and he completed clinical research training at the Bloomberg School of Public Health under the mentorship of Dr. Gregory Kirk. His current research project involves interventions to improve quality and continuity of care for HIV-infected patients, with a special emphasis on people with psychiatric illness, people who use drugs, and prisoners. Since 2001, he has been a care provider for the HIV/AIDS Comprehensive Care Program at UW hospitals and clinics. So with that, I would like to hand it over to Dr. Westergaard. And also I want to say thank you to everyone for completing the poll. It just gives us a little bit of an idea, and also Dr. Westergaard, of who is on the call. So with that, we'll hand it over to you, Dr. Westergaard.
Thank you very much, Jeannie. And thanks to all of you who have joined as participants over what I imagine is your lunch break. Happy to be able to share some of the experience and data that I've been involved with collecting and analyzing here, and hopefully to provide some useful information about HIV and viral hepatitis. So over the next 45 minutes or so, I hope to define what I mean when I use the word syndemics, which may be a new term for some of you. In short, it's a short term for synergistic epidemics or intersecting epidemics, which is what I use to describe the co-occurrence of HIV and hepatitis in substance-using populations. I thought it would be interesting and kind of fun to illustrate this using data from our 6-state region. So I've gotten some public health surveillance data and other things that have been aggregated from state health departments, and have shared that in some of the slides to provide some background. And then specifically, and what I think our main intention of this session is to talk about the roles that healthcare providers, and particularly behavioral health providers and addiction treatment specialists, can play in addressing syndemics. And specifically, I would talk about how we can use the engagement that people in addiction and behavioral health can have in terms of doing the necessary tasks of screening and linkage to care. And then I want to talk about some research that shows how we can do better by our clients and patients by co-locating treatment and providing care coordination services. So I was struck recently to read about someone who took issue with using the term epidemic to describe what's going on with opioid use in this country, because I thought it had a fair amount of face validity. So I went back and just made sure, but we're all talking about the same thing. To me, when I think about epidemic and what I've looked up in this dictionary of epidemiology, it's talking about the occurrence in a community or region, cases of an illness, specific health-related behaviors, or other health-related events that are clearly in excess of normal expectancy. So I think about it in terms of things that we can count or measure. A lot of the things, the events, behaviors, and illnesses that are related to the opioid epidemic are difficult to measure, but the ones that are easy, such as overdose-related mortality, has clearly shown that this is what I would think everyone could agree is an epidemic and beyond what has been considered the baseline. So this is national data from 1999 to 2016. If there is a expected baseline, I think I don't want to use the word that we ever expect people to have overdoses, but there has been a historical baseline that really started an increasing trend in the early 2000s. And then in the first part of this current decade really took off dramatically, driven really by synthetic opioids other than methadone and heroin. Every state in our region has experienced, and frankly every state in the country has experienced a rise over this time. And these are data from Wisconsin and Minnesota that break it down in the same way, showing that both prescription opioids and heroin have increased. In both Wisconsin and Minnesota, prescription opioids to date have contributed to a larger number of the opioid-related deaths than heroin, but heroin is on the rise. All of the other states have shown similar patterns, and this badge on the upper right-hand corners is a link to nationally aggregated data by the National Center for Drug Abuse and CDC, which takes data from the National Health, or coordinates to the National Health Statistics Center for every state. So you can click on there and look at a number of different opioid-related health indicators for every state. If there is an outlier among our 6-state region, it's Ohio, only in that it has been more severe than all the other states. Ohio is in the top 3, with West Virginia and New Hampshire as having the highest rates of opioid-related overdose deaths. So one other interesting way and really striking way to look at the contribution that opioids has had during this epidemic is its relative contributions to the leading causes of injury death. And the State Health Department in Indiana created this slide to show that between 1999 and 2009, these have been the changes in the top 5 most common causes of injury-related deaths. So homicides by firearm and traffic accidents have gone down somewhat. Unintentional falls and suicides have gone up, but unintentional poisonings, and this is almost exclusively driven by the changes in opioid overdose, has gone up by 500%. So I use the term syndemic, and here's how I would formally introduce that. So 2 or more afflictions interacting synergistically, contributing to excess burden of disease in a population. In syndemic theory, individual epidemics are sustained in a community or population because of harmful social conditions or injurious social connections. Syndemic theory is a relatively recent term, and as far as I can tell, it was first used in the mid-90s to talk about the epidemics, the intersecting epidemics of substance use, violence, and HIV/AIDS in New York City, and it was popularized by this seminal work by Merrill Singer in 1996. In the current context, I'm referring to a syndemic of HIV, hepatitis C, and opioid use disorder. And it's hard to say precisely when this current syndemic started, but I think the slides that I showed previously show that it's definitely the past decade has really taken off. The figure I think is helpful because when we talk about syndemics, we talk about shared underlying root causes or social determinants of health. And it shows how these various things, some of which I'll talk about in my later slides, such as poverty, such as intermittent incarceration or involvement in the criminal justice system, and substance use sort of are shared risk factors for HIV and hepatitis C. And certain aspects of these related to the stigma associated with them and shared risk factors of poor engagement or poor access to services can make all of these worse. So this is the slide that I thought best introduced why I call this syndemic. These are Wisconsin data and maps the increase in heroin overdose deaths with the new reports of hepatitis C cases, which I abbreviate HCV for hepatitis C virus, among people aged 15 to 29. And over the same years, they've gone up in parallel to quite a large degree. Interestingly, what looks to be a downtick between 2015 and 2016, I recently learned from talking to colleagues at the health department is really a statistical anomaly because of the way that the way they collect and characterize active infection versus positive screening tests. So in reality, it has continued to increase even from 2015 to 2016 and then subsequently to 2017. This increase in hepatitis C has been going on everywhere. Wisconsin's not unique, but northern Wisconsin is one of the first places where this clusters were detected and then reported nationally. This was an MMWR from 2012, and it was some very astute public health officers in a cluster of northern Wisconsin counties that showed an unexpected increase in the number of young people with acute hepatitis C. That was sort of the very first signal, and the graph on the right shows how since 2010, both injection drug use and acute hepatitis C cases have gone up in parallel. So hepatitis C, despite the title, I think I'll spend more time and more slides talking about hepatitis C just because it has the extreme burden and the increasing importance of this infection in particular over the past decade. Some may not be aware, but it was as early as 2006 that deaths from hepatitis C outnumbered deaths from HIV/AIDS in the United States. And 6 years later, analysis by the same group at CDC showed that deaths from hepatitis C outnumbered deaths from all other reportable infections combined. This has really changed the whole epidemiology of hepatitis C in this country. This slide is actually taken from Massachusetts, who is not one of the states in our area, but they make the best graphics that I can share. And it shows how in 2002, and in 2002 I was a medical student, and the teaching for medical students at that time was that hepatitis C was a disease of baby boomers because it was circulating in the population in the 70s, 80s, and 90s. Of course, hepatitis C wasn't discovered as a virus until around 1990, so the blood supply hadn't been screened for it. So most of this mass of people in the baby boomer generation, or the birth cohort from people born in 1945 to 1965, were infected without knowing it, and there was this large latent pool of infected people who didn't know they were infected. So by the time I was an infectious disease fellow in 2009, that story had changed, where yes, there was still a large cohort of people who were infected from that baby boomer generation, but there was a second hump, a bimodal distribution of people who are acquiring hepatitis C through behavioral risk factors, specifically injecting drug use. And this was seen in Massachusetts, and at least reported in MMWR in Massachusetts really before anywhere else. These data, they didn't have the third graphic that showed the third panel in the way that would fit nicely on the slide. But in 2014, 2015, the hump on the left, the young injection drug use cohort, is actually quite a bit bigger than the baby boomers. So this is changing before our eyes, and definitely in the midst of an evolving epidemic of hepatitis C. So this story that's been unfolding and has been told with a great deal of scientific rigor and collaborative work in Indiana is probably the best recent case study to understand how these two infections and injection drug use and opioid use disorder are related. We don't have time to go through all the details. I'm sure that many of you have heard about this or read about this, and for the ATTC, it may be worth a specific session to have on this because there's so much to learn about what went wrong and then what went right about the response to this outbreak in Indiana. But to give the highlights for those of you who may not be aware, in Scott County, Indiana, which is a rural county in southern Indiana with a population of just over 4,000, there was a cluster of HIV cases that was detected during the first half of January 2015. Historically, there was almost no HIV reported or known about in this county. In fact, for over those 4 years, there were only 3 cases that had been reported. And by the time this slide was made, there was 173 cases. When I did a Google search last night to see how many have been reported to date, it's over 230. What was unique about this case is that although hepatitis C had been, epidemics in clusters of hepatitis C had been linked to injection drug use in non-urban settings, this was really an explosive epidemic of HIV, which hadn't been seen before. And it took a very large and rapid investigation to get to the bottom of what exactly was going on. What was learned from the local and national investigators was a community that was really devastated by multi-generational drug use. And by that means that adults and adolescents and their parents and their grandparents were using often in the same house and often together. Sharing of injection equipment was common. People were injecting multiple times per day and had multiple partners with whom they would share injection equipment. The review of the first 135 cases showed that this was predominantly young adults, a median age of 32. Both men and women were similarly affected, and 100% of the racial ethnic group were non-Hispanic white. Scott County was a community of high poverty and unemployment and low educational attainment. For hepatitis C, it's notable because we're talking about how these things travel together, but not as well publicized that this was an epidemic of hepatitis C as well as HIV. Among the people who were detected as having HIV infection, 95% of them had hepatitis C. And of the contact tracing that they did, meaning when public health officials investigated cases and said, who have you potentially been exposed to, and they did testing there. Of the HIV negative contacts, 60% were hepatitis C mono-infected, meaning the number of people infected with hepatitis C was much larger than the number infected with HIV. There's been a lot of very interesting and actually some important advances in public health science and technology that have been stimulated and really put to use in the Indiana outbreak. And this is not new. This is essentially types of network analysis and contact tracing that's been done, but it shows a number of different parameters on the same graph. The high degree of connectedness among people in the community. So every blue line is a reported sexual partnership. Red lines are people who had sexual exposure and injection drug use, and the gray line is injection drug use only. And there's a tangled web of people in this small community that were exposed to each other. The larger circles are people who reported more connections, and the highest risk here, and it's by size, was 56 high-risk contacts. And the red dots were people who tested positive for HIV. The blue were people who tested negative. So this just shows that there's in a community where there is a lot of connected and people have large networks and overlapping networks, and safer injecting practices are not followed, these infections can spread quite quickly. The thing that I think is most important for us to talk about or learn about from the Scott County outbreak is actually the response to it. And this slide was taken from a presentation from Dr. Janowitz, who's from the University of Indiana, that showed the different partners and the different stakeholders that were in. And I knew immediately when I saw this slide, I haven't met Dr. Janowitz, but I knew from this slide that she was a fellow infectious disease and HIV provider because of the way that she put viral suppression at the middle, which I don't think everyone thinks about that way, but for reasons I'll talk more about. when we're dealing with the response to HIV and how to prevent HIV from spreading and how to prevent death and illness from HIV/AIDS, the only tool we have or the most potent tool we have, I shouldn't say the only, the most potent tool we have is to get people's virus in their blood suppressed to undetectable levels. And we do that with antiretroviral medication. So she thinks about this the same way that I do, that we have a lot of services that go into getting people tested, diagnosed, linked to care so the virus can be suppressed. And when that happens, people don't transmit the virus to others through sex or through needle sharing, and they don't get sick with complications of HIV/AIDS. This was a nice figure that showed sort of how rapidly and efficiently some of the major events in the epidemic response unfolded. It was really over just a year and a half that from the initial case was made and the cluster was identified, that local policy had been changed, a new HIV clinic had opened up, syringe exchange, which had been illegal across the state, was allowed in the setting of this public health emergency. It was reported nationally and got a lot of attention, they've, in my opinion, have done an admirable job sharing lessons learned from this outbreak. So overall, what is there to learn from this? What is very clear that the environment in which this happened was one where there was very little awareness of HIV or hepatitis C in the general population. There was no education about HIV in schools. Syringe exchange was not permitted by state law. The Robert Wood Johnson Foundation does the county health rankings so looking at publicly reported data, what are the counties in each state that have the best health and the worst health. So Scott County had traditionally been 92 out of 92 in Indiana. So it was a state with not a lot of a county with not a lot of resources. They had no addiction services, and for reasons related to that I don't have a lot of insight into, this particular drug, oxymorphone, was widely available and used by the majority of people on a daily basis, which actually, and interestingly, because of this particular drug, might have increased the risk of disease transmission. As we've learned, oxymorphone is a pill that's difficult to dissolve. The pill is difficult to crush, and it requires a larger volume of solvent, which is usually just heated water, to dissolve into the point where it can be injected. So the result of this is that people need to inject a larger volume, sometimes having to reload their syringe before they inject. It also has a relatively short half-life, so people inject more frequently during the day. So these are risk factors that increase the risk of unhealthy or dangerous injecting that can increase the risk of HIV transmission. But like I said, in the aftermath, and the success story about this is when I mentioned that I looked for the most recent reports out of what's going on in Indiana. And in 2017, there were only 12 new cases of HIV diagnosed after there had been 270 in the year before. So they've reached the majority of people in the county have been tested. Most of the people who have been diagnosed with HIV are on treatment. This news article that I read said that they were ranked 91 out of 92, which was a good thing. So they were no longer in last place on a whole number of health indicators. So they've been able to get some more resources. And I think the state health department and really around the country have learned a lot that there's not, while Scott County may have been highly vulnerable to this type of epidemic, there are many counties, particularly in this region, in the Appalachian region, in the Ohio River Valley region, that are highly vulnerable to these things. And it's really been a call for health departments and public health researchers like myself to think about what can we do proactively to make sure that the resources are available to prevent this in the future. So that was quite a long introduction to getting to this slide, which is to answer the question of the title: what do I believe addiction treatment providers ought to know about HIV and viral hepatitis? And so I'll spend the second half of the talk sort of going through these three main take-home points. The first is that the necessary response to HIV and hepatitis C is a continuum of care. The second is that populations at the greatest risk for HIV and hepatitis C also face substantial barriers in navigating health systems. And then finally, I'll talk about two promising approaches, or two what I just think are valuable components of a public health and medical approach to addressing the syndemic of HIV, hepatitis C, and opioid. And one is the co-location of services, and the other are various ways of conducting care coordination. So a continuum of care is something that in the field of HIV and increasingly Hep C, we talk about a lot because of this kind of seminal article by infectious disease doctor named Ed Gardner in Colorado, who articulated something that we sort of all knew intuitively, but gave a really useful framework for talking about how HIV care should work. And the continuum, or the spectrum, is that over on the left side of this figure, there are people who are in the community, unaware that they are HIV infected, and therefore not getting any care or services. They are the highest risk for disease progression because they're not being treated. They can also spread the disease to other people because they're, and we know from CDC data that shows that over 50% of new HIV cases are the result of exposure of a person who was unaware that they were infected. On the other end of the spectrum, what is someone who's fully engaged in care? And what does that look like? Well, in our HIV clinic, the general expectation is that people are seen at least once a year, but probably twice most commonly. We monitor their blood work to make sure the virus is undetectable. They have consistent access and perfect adherence to their regimen of antiretroviral therapy. And then there's in the spectrum, and there's gray areas. There are people who are receiving some care, but not HIV care. There are people who are lost to follow-up, or people who are in and out of care. And there are people who have lives who are complicated and other things take precedence over the HIV care and have what I call lapses in care, or viral rebound, where for 6 months out of the year the virus is undetectable, and then something comes up in their lives and they stop their therapy and the virus rebounds. These are the things that we try to avoid. And I think the reason that this paper resonated so much in the HIV community is because it was in a period historically where we were really collectively patting ourselves on the back for doing a great job with HIV, where in most patients in 2010, 2011, you come into an HIV clinic, the majority of our patients that we see on a daily basis are taking their medications, have an undetectable viral load, life is going well. This was firmly in the single tablet regimen era, meaning that most people, when they were starting, could get a full HIV regimen of 3 different drugs co-formulated into a single tablet. So HIV care was easy, and most people that we saw were doing great. But what was so important about this analysis was that, well, we're only seeing people who are showing up and doing well. And when you look at the overall proportion of people who are living with HIV in the country, it's actually only about 20 to 25% we'd say are a success. And there's, at every step in this continuum, there are people who we lose, or people who sort of fall through the cracks. Meaning that at that time, only about 80 to 85% of people, we estimated, who were HIV infected were actually diagnosed. Of people who'd been diagnosed, some people decide not to establish care or had not been linked otherwise. People who are linked to care, sometimes people aren't retained in care. Not everyone who was in care had been started on antiretroviral therapy at that time. Of the people who are on antiretroviral therapy, not everyone was perfectly adherent and had an undetectable viral load. Although, like I said, most people who showed up and got their medication, the medicines are so effective that they were undetectable. So it was this, they called it the cascade, and some people call it the Gardner cascade, where every step represents some inefficiencies in our overall continuum of care, which means that at the end of the day, we're not doing as well as we thought we were. This is a model that I think just about every clinical research or every sort of public health HIV talk has some version of this slide, and CDC has really embraced it and is set national goals on how to improve the various aspects of this continuum of this cascade. So how are we doing for hepatitis C? Well, much worse actually, for a number of reasons. There's about 10 times more people with with hepatitis C than HIV, and 50% of them are undiagnosed, whereas I think CDC believes about 89 to 90% of people living with HIV have received their diagnosis. Still about half of the people in the U.S. are unaware that they're HIV, that they have hepatitis C. Hepatitis C is also different in a couple of important ways. One is that if someone has a positive hepatitis C antibody test, they have about an 80% chance of having chronic infection, but there's a lucky 20% who clear the infection and are no longer viremic. So testing is a two-step process that requires a blood draw and a somewhat complicated conversation to explain that to patients. So it's a little bit, so testing is a little bit more challenging to operationalize. The other major difference, which is I think a good difference or something fortunate about our approach to hepatitis C, is that it's curable. So whereas HIV requires a combination of antiviral medications to be taken lifelong, there has been a veritable revolution in therapeutics of hepatitis C in the past 8 years, whereby hepatitis C is curable in almost all cases with a 12-week course of medications, and over the past several years, these have also been able to be co-formulated into a single pill. So as recently as a decade ago, treatment for hepatitis C took up to a year, involved injectable interferon, made people feel like they have the flu, and so that for that reason, the discussions with providers was often like, well, how bad is this, doc? Is it worth taking a medicine that's going to make me feel terrible for a year to get rid of? These days, the treatment is taking a pill with few to no side effects, 1 pill a day for 8 to 12 weeks, and people are cured 95% of the time. So it's really changed dramatically. But despite that dramatic advance in therapeutics, only 6% of people infected have received treatment and have been cured to date. There's complicated reasons why that's the case, but that's where we are. So this was a link that I think is of high relevance to this group and to this talk. And Jeannie and the ATTC sent out a link to this a couple of weeks ago. So I thought it was worth highlighting. The SAMHSA sent out this advisory about hepatitis C screening in the behavioral healthcare setting. It's I think a 3 or 4 page document, maybe a little bit longer. If you go through your email, the same sender as that you heard about this talk, you should be able to find it. But I've distilled it down to the 2 main recommendations of how we approach screening for hepatitis C. And one is that it's still important because many have not been diagnosed, but adults born in 1945 to 1965 should receive one-time testing for hepatitis C without any thought of what their risk is, because just being born in that cohort is such a risk of having hepatitis C, even through blood transfusion or through incidental healthcare exposure or other contact. The second, which is highly relevant to providers who are involved in addiction treatment, is that routine hepatitis C testing is recommended for all people who have ever injected drugs illicitly, including those who have injected once or a few times many years ago and do not consider themselves regular users of drugs. So injecting drugs at any time at once is a risk factor and is probably even a higher risk factor of being born in that birth cohort. And so testing should be done on a routine basis. And similar to how we've tried to move the needle on HIV, where I said 15 years ago, 75 to 80% of people were diagnosed. We've gotten that number up to 90. 90 is probably not good enough. We'd like it to be even higher. But one of the ways we did that is to encourage that HIV testing can be part of routine healthcare across all settings. It's maybe not feasible to happen in every setting, but the more places that can incorporate screening for HIV, the better. And so emergency departments and dental offices in some cases have been offering this as screening, which has really helped us get there. And I think something similar would be beneficial to happen for hepatitis C. The same advisory showed results of a survey that they did of substance abuse treatment facilities that participated in the National Survey of Substance Abuse Treatment Services, of how many offer hepatitis C screening versus how many offer hepatitis education, counseling, or support. And if you look across all facilities, about 23.8 said that they offered hepatitis C screening. 45.9% said that they offered hepatitis counseling or support. If they were sites that provided general health care in addition to substance abuse treatment, they were higher than average. The rest of it, they were specifically mental health service providers or substance abuse treatment were low. And this comes directly from the text of this advisory. So in a heading called "What HIV-related support can behavioral health providers provide to clients?" Well, first is that they could help clients understand their test results, which in some settings might require that staff or counselors receive a little bit testing, but it's something that having done research and having worked with these clients isn't a given that patients understand what the heck we're talking about when we say, well, your antibody test is positive, but you don't have hepatitis C. Or likewise, if someone has a hepatitis C antibody test that's positive, if we treat them and cure them, if we test them a year later, their antibody tests, because antibodies stay in your blood for life, would still be positive. So we need to do a second nucleic acid test where actually looks for the viral nucleic acid to know whether they're chronically infected. So there's some complexity related to hepatitis C screening that it's helpful for health providers to be able to help patients understand. Other thing that they can do is counsel clients about how to avoid infecting others and the importance of doing so, and refer them to help in finding resources to pay for their hepatitis care and treatment. And finally, which I thought was interesting and exciting to see in this document, is that providers, and I think this is sort of we in general, providers can provide advocacy and support to ensure that our patients are not unreasonably or unfairly excluded from antiviral treatment. So what's that getting about? So this is something I thought would be worth sharing because it's something I hope is in flux, and as policy changes, the way that we can interact with our patients in non-infectious disease clinic settings might change, and there may be a larger number of places where people can get hepatitis C treatment. But as of right now, there's a lot of insurance restrictions, and that's probably the biggest reason that only 5 to 6% of people living with Hep C have been treated to date, is that although the medications are extraordinarily effective and well tolerated, they've been priced extraordinarily high, and insurance companies, Medicaid among them, not in my opinion because they wanted to overtly be discriminatory, but rather as a means of rationing care and not busting their state budgets, put limitations on who could get hepatitis C treatment paid for. So the three main restrictions that they've done, these three categories, one is that they favored people who had advanced liver disease. So this has been a moving target in most states. People had to have a biopsy showing significant fibrosis of the liver before they would be qualified to have treatment paid for. A second is that people who have active substance use disorder shouldn't be eligible because, well, I think that's arguable what the rationale for that is. I think on one hand, they're likely to, or possible to get reinfected, and you could see a policymaker saying, well, we're not going to spend money on people who are likely to become reinfected. The flip side, in my opinion, is that this is the population most likely to transmit virus, so we should actually prioritize treatment of people who inject drugs. But of course, the right answer is to manage and approach all these things at the same time. And yes, treat patients with hepatitis C who are injecting drugs, but also get them evidence-based treatments that we know can help them achieve remission and be in recovery. And then finally, in the old days, in the interferon ribavirin, it was a very complicated regimen. There were side effects and toxicities, and people had to adjust doses when they got anemic. So there were restrictions on what providers could prescribe these newer, more expensive antiviral medications. And many states still allow only gastroenterologists or infectious disease specialists to do it, which is really unnecessary because the new drug, like I said, it's one pill once a day for 8 weeks with very little toxicity, doesn't really require monitoring. Really, you don't need to be fellowship trained to be able to do that. This website shows where these are. There's actually a map of the entire country where you can go to your state and find out what are your state's current policies. I took a screenshot of me hovering over Wisconsin, and it shows that the state of Wisconsin is getting a D. And then if you click on the state, I think actually the next screenshot was actually of Illinois. So Illinois is, Wisconsin's a little better than Illinois. Illinois has a D minus, but we have a straight D. But then it'll say what are the policies in Illinois that are in place and what are the recommendations. And the context, the reason that this is like, what's the point of having this website? It really is an advocacy, and it's an initiative of the Harvard Health Law and Policy Innovation Group. And it's the same group that, I'm going to go back one now here, looked at the states that get an A. So Washington State has an A, Connecticut has an A. This isn't live, but if you hover over them, you'll see. The reason that the state of Washington has an A is because they were sued. Because some patients or group of patients said, well, it's not fair that you will not treat me because my liver is okay. I don't want my liver, I don't want to get fibrosis before you treat me. And a judge agreed with them and issued an emergency injunction, says this policy is unfair to people who are not sick and they should treat them, and so now they have no restrictions. And so that among health advocates is the direction which we hope most of the country is going. And this website is a way to kind of show how we're doing in real time. Because when you look specifically at the data about the benefits of treatment, there is no reason that anyone living with hepatitis C shouldn't be treated. And this is also a screenshot from the American Association for the Study of Liver Diseases and the Infectious Disease Society of America joint recommendation on hepatitis C treatment. And the recommendation is treatment is recommended for all patients with chronic hepatitis C infection, period. I was expecting to say period, but it does have an except. And it's essentially if you're dying of liver disease and hepatitis C isn't going to make a difference, then they don't recommend treatment because it's not likely to be beneficial. The health benefits of hepatitis C eradication or cure is that it halts liver disease progression. So someone is really at the end stage, they're not likely to have to benefit. The other fact that I think means that these policies are off target is that there's plenty of data. This is a figure from one study that looked at a series of 1,000 patients, but there are other studies showing the same thing, that given appropriate support, people who inject drugs have comparable outcomes, of just as likely of getting cured of hepatitis C if you give them the treatment as those that don't. This is the most exciting slide, in my opinion, of the whole talk, and this is very hot off the press data from a few months ago at the European Association for the Study of Liver Disease, or EASL, in Paris. And it took everything I've been talking about how viral cure prevents transmission and how treatment is an important lever in public health response, and institute this on a national basis. So there are 2 states or 2 countries in the world that have created national goals of eliminating hepatitis C transmission: Iceland and Georgia, the country of Georgia. And these are some early data from how that process is going in Iceland, where they're trying to screen everybody at risk. They're trying to provide treatment for everybody who has hepatitis C. And although the blue line, which shows that the injection drug use has not gone down, it went up over the last few years, similar to how it has in North America, hepatitis C incidence has gone down. So contrast this to the slide I showed from Wisconsin, where they're going up in parallel. In this situation, just by treating a massive number of people who are at risk, they've been able to turn the epidemic curve for hepatitis C. And this was a press release and a quote from a doctor in Iceland who said, encouragingly, even individuals with recent injection drug use, DAA treatment, and that's direct-acting antiviral treatment, resulted in 87% cure rate, including those that did not complete the treatment regimen, said Dr. R. from Iceland. People who inject drugs are the key drivers of hepatitis C infection in Iceland. This population should be the focus of treatment scale-up. We would like to emphasize and encourage collaboration between addiction treatment centers in both screening and treating HCV. This is the key to success in reaching our population of focus. So the second take-home message that I wanted to share, and in this one I'm going to take the liberty of sharing some data that I was involved with collecting and analyzing, It's that it's not easy. I think again, in my opinion, it's wrong to exclude people from treatment that's beneficial on the basis of a behavior that they inject drugs. But it's not to say that it's going to be easy or effective if we make treatment available for everyone. As all of you know, people who have substance use disorders, they can have complicated lives and barriers to care. So this is an analysis of the HIV care continuum, which is similar, modeled after the one from the Gardner paper that I showed, for people who are participants in the ALIVE study, which is a community-based cohort. And what I did in this figure is to show that yes, when we look at a one-time, like of the whole sample, how many people are linked to care, 93% had been linked to care. That's good, of course. When we looked at sort of over time, over a period of several years, how many remained engaged in care, it was relatively few. So only 30% were engaged in care during every year, meaning they had at least a visit, a clinic visit every year they were in the study. Similarly, fewer than 20% who started antiretroviral treatment stayed on it, meaning over 80% stopped at some point. And then we looked at the viral suppression, which I mentioned is sort of the holy grail of HIV care among those of us that do it. Although 65% achieved an undetectable viral load at some point, only 8% had a viral load every time thereafter. So interruptions in care are very common. And this is, I won't go into this in detail, but we did a statistical analysis of when we looked at someone who went at one visit to having an undetectable viral load, and then at the follow-up visit had a high viral load. What were the top predictors? What were the things? And number one, and by far number one, was whether they were incarcerated. Other ones were cocaine, unemployment, homelessness, and whether they injected any drugs. So this gets back to that syndemic slide. These are things that are causing life to be difficult, for people to have trouble accessing care, for people to be engaging in risky behaviors. And this is a slide that I've shared elsewhere to show that, particularly in this criminal justice population, the prevalence of these things, of substance abuse, mental illness, viral hepatitis, is actually quite high. And as a result of this, when you look at the prevalence of HIV among hepatitis C among people in the U.S. who are in prison, it's several-fold higher than the general population, 4 to 5 times more. And in hepatitis C, the disparity is even greater. So the third take-home point, I wanted to just show a little data and maybe plant some seeds about promising approaches to addressing these epidemics with shared risk factors, one being co-location of services, and the other to talk a little bit about the role of care coordination and some of the research we've done about that. So for co-location, the idea is that the barriers that we talked about, could they be better, or could services be accessed if we had one-stop shopping, if you will? And that was one of the messages out of the Indiana outbreak, is that I think they actually called it the one-stop shop, is people could come in and get tested for HIV and hepatitis C. They could get enrolled in insurance if they were eligible. They could get a link to a primary care provider. So making it easier for people to get the services they need by putting them in the same location. So this study is also from the same liver conference that I've mentioned. I thought was very interesting because it was the first time to my knowledge that in a clinical trial, there had been many clinical trials of these newer hepatitis C drugs, and that's what this SOFVEL is. It's sofosbuvir and velpatasvir. So it's one of several newer, highly effective regimens for hepatitis C virus. But then in the sub-study, this protocol, they kind of bundled it with buprenorphine, thinking that people would have better outcomes if they had a substance use disorder, if they treated the substance use disorder at the same time with the hepatitis C virus. It was a single arm. It wasn't they didn't randomize people to MAT or not, but they compared it to the other ones and found that most people who received both or co-located treatment did well. 91% had SVR, which I should have defined earlier, I apologize, as a sustained virologic response. That's the way we say cure in hepatitis C to make ourselves sound like we know what we're talking about. And when they looked compared to other people in the parent study, people who received MAT were significantly more likely to come and fill the their second bottle, meaning they would probably get a month of supply, and then they'd have to come back and get the other one. Meaning people that didn't get co-located buprenorphine and study drug were more likely to drop out. And then when they measured HIV risk behaviors, which I presume means injection or shared unhealthy injecting, it decreased significantly over the course of the study when people were also on buprenorphine. So the last thing I wanted to talk about is approaches to care coordination. The experience that I just highlight, again, from here in Wisconsin, we were part of a collaboration among 6 states. None of the other ones were in our Great Lakes region, but funded by HRSA to try to solve this problem of this revolving door of some people getting lost to follow-up or disengaged from HIV care. And what most of the sites did some variation on this theme was to embed patient navigators, which goes by other names, intensive case management. So case management is common in most of our specialty HIV clinics, but patient navigation sort of takes that to the next step, where people can go and get rides and meet them in the community if they have trouble getting to clinic, have a smaller caseload. There was a large evaluation of this, of both using in-depth ethnographic and qualitative methods, as well as the statistical measures of HIV outcomes. The stuff that's been published already is really showing sort of the emotional support. And these were 2 groups that our collaborators that did the qualitative analysis showed, is that it really fit an unmet need for people that were really struggling. They are resource intensive considering the small sample size, but fill an important gap in overtaxed case management systems. And talk about people, what we heard is that people who were in this program, knowing that someone else was out there that they could call, who cared about them, who cared whether they were well or not, had a big intervention effect. They realized that some of the main barriers to care, which aren't really identified in a lot of clinical studies, are social isolation and health literacy and low motivation, failed linkages. And this need that people talk about is about having a personal relationship with their care providers, whether it be their physician or the nurse or their patient. People have a different mix of these resources, and the thing, in my opinion, about why these case managers are successful is that they can be patient-centered and individualized. We have started to look at some of the quantitative outcomes, and this shows specifically people who were in prison and then participated in this study afterwards were more likely to be linked to care and stay on their medications 6 months after they were released from prison than those that weren't. And this mirrors other studies elsewhere that show that this type of patient navigation intervention can increase linkage to care for people when they get out of jail. This group in San Francisco was one of our collaborators in that linkage to care study. This was a different project, but they're the same investigators, and their conclusion was that patient navigation supports maintaining engagement in care and can mitigate health disparities, should become standard of care for HIV-infected patients leaving jail. So can these things also be useful for hepatitis C and opioid use disorder? Well, the answer is almost certainly yes, and a lot of different things have been tried. These are a couple, a quick search shows a few abstracts and things that essentially use similar methods to take people who have been diagnosed with hepatitis C, either in a community-based setting or in jail or in behavioral health or addiction treatment, and help them get the services they need. They're called a lot of different things. They're called patient navigators, recovery coaches, or linkage to care specialists. When they're evaluated, they're all usually fill some need and are beneficial in some way. They're not well standardized. There's not a cookbook that says exactly how to do them. That's sort of an area of research which I think is useful, of how to do this in a way that is reliably effective and cost effective. And the biggest challenge, I think, and this is something that I think is another sort of a policy-rich topic, is that there's not funding to do care coordination for hepatitis C and opioid use disorder in the same way there is for HIV. There's a lot of HIV exceptionalism, which is a good thing. It's based on lobbying by affected populations, and those things just don't exist so much for hepatitis C and opioid use disorder. But one of my goals as a researcher is to sort of start creating the database that we can argue that these things are important and will be necessary. So in conclusion, I think given all of this, we need to collaborate and share experiences from people who work with people living with HIV and other infections and people who do addiction treatment, and disseminate works to improve care with people living with HIV and opioid use disorder. And I'll leave you with the quote, which you can read on your own. I left less time for questions than I'd hoped, but I think we have a few minutes to take any questions and have discussion.
We do. Thank you so much, Dr. Westergaard. There was a couple polling questions that we're just going to put up right now. You'll be able to see them on your screen, and these are just for Dr. Westergaard to get a kind of an idea about where you're working and what you're doing. So the first one is testing for hepatitis C infection offered at the main site where you see patients and clients? And then the second question will come up shortly. But Dr. Westergaard, just a couple questions that we have in the chat box right now. The first one is clients that are undetectable, are they still carriers?
In the case of, it's an excellent question, and it varies depending on which virus we're talking about. So in HIV, if someone has an undetectable viral load, they are not cured. That is the bad news. So we have not been able to cure or eradicate the HIV virus from people with treatment. There's a lot of effort, there's a lot of research going into how to do that, but all we've been able to do with drugs so far is to suppress the virus that's circulating in the bloodstream to undetectable levels. But the virus is still in the body. It hides latent, dormant in lymph nodes and in circulating memory B cells. The implication of that is that if someone stops their antiretroviral therapy, the HIV will invariably come back. So that's different. The answer to that question for hepatitis C is the opposite. So there is no latent reservoir of hepatitis C. So it's predominantly in your liver and also in your bloodstream. So when someone completes the 12-week course of treatment for hepatitis C and there's no detectable virus in their blood, that means they're cured and there's no virus present, and it really halts all the damage that was being done. So unfortunately, people can get reinfected. So a challenge to the screening piece for hepatitis C is that there are rapid field point of care tests for hepatitis C antibody tests. So you can go into here in Wisconsin, we work with a syringe exchange program. You can go in and someone can get their hepatitis C test, and if their antibody test is positive, and they've never been treated, that's a good indicator that they have hep C. But the problem is that if they have been treated and they're cured, that test will still be positive the next time. And if they relapse and if they need to get screened again, we actually have to use a more expensive test to detect the virus. So that's a good question.
Good, thank you. Another question here is, are there examples of integrated risk assessments for infectious diseases, including HIV, hepatitis C, and STDs for use among addiction treatment providers?
That is also a good question. I've seen, in my experience, most of the HIV risk assessments that are done are home brews, if you will, meaning there's some screening questionnaires that go along with, for example, like I was mentioning if someone gets tested for hepatitis C, there's a risk assessment that goes along with that. There's not one that I think sort of dominates clinical practice. There are some that are used in research. There's one called the risk assessment battery, and there's some longer ones that are in a lot of detail. But I think it's really an unanswered question of what is the best tool for that in behavioral health settings. And I'd be happy to look into this further, and if I can be available by email and this might be a good forum, the ATC network, to disseminate if there were going to be a standard short question, what is there an instrument? But essentially, we need to ask people for both of these. Are you injecting drugs? And if you inject drug, are you using any aspect of any of your equipment at all that you use for injecting, whether it be the needle, cooker, the cotton that you draw through the container, any aspect of the rig that where people use to inject drugs that contacts the blood can harbor the hepatitis C virus. So we have a lot of people who are very assiduous about not sharing needles, but are still hepatitis C positive. And when you dig deeper, they have the same little cooker or the same container that they draw their drugs out of. And the needle that was in their vein went into the same liquid that someone else is drawing out of, and that can actually transmit virus. So there's some nuance there to be sure, and I think it probably does call for a standard risk assessment. So that'd be something I'd be happy to look into.
Great, thank you. We'll do one final question because we are at the top of the hour. There's a question here that says, does cost of medication for hepatitis C cause many to not be able to afford? I think she probably meant treatment after that. So does cost inhibit people from?
I think that's the biggest barrier to getting people treated, actually. Like the slides that I showed about the Medicaid restriction, that's really the crux of the issue, is that they're new medications. The companies are trying to maximize profit by making these drugs available because they've invested a lot of research and development into creating the drugs. So that's the model that we have, unfortunately, for better or worse, I would say. I think there's good things about how drugs get developed in our system, but that's really the biggest gap right now, is that the medicines are not affordable to almost anybody. I mean, without insurance, and insurance is to protect their bottom line, have to ration and restrict how many people are affording it. So that's something that really needs policy and really sort of needs literally Congress to step in and say this. To address this public health issue, we need to do something about the costs.
Good, thank you. Thank you to everyone who has done the polls and answered the questions there. We're going to close those out, but thank you. It's very helpful information to all of us, and obviously probably to you folks, and also to you, Dr. Westergaard.
I do want to say I saw the comments from Ricardo, who made a good point when I was talking about undetectable means not cured, and he raised the question, which is sort of a message that we're trying hard to get out, which is that undetectable means untransmissible. So while I think the question was, people who's undetectable viral load, are they still a carrier? Yes, that's true that that they're carrying the virus in them, but we have really good science that says if the virus is undetectable in the blood, that they're not contagious, meaning that they're, in this, I think there's been a lot of important sort of anti-stigma work that shows how it's valuable to know that study after study shows that someone is undetectable. They don't transmit the virus to others through sex or needle sharing.
Thank you. Well, thank you, Dr. Westergaard. This has been fantastic. Thank you to everyone who was able to join and for the great questions. The recording and the slides will be posted on our website within the next week. We will also have a link for the next webinar in this two-part series shortly for you. And again, that is July 19th at 12 noon Central, 1 Eastern time. Thank you to everyone, and thank you, Dr. Westergaard. Really appreciate it, and have a great day, everyone. Thank you.